Assalamu alaikum. My name is Adia from Group 50. My roll number is PP165007. The topic that I am presenting is disorder related to menstrual cycle, dysmenorrhea. What is dysmenorrhea? It is a pain that is associated with menstruation. It is a sharp, delicate pain in the pelvis or lower abdomen. Dysmenorrhea is the single largest cause of the lost productivity and the school absence among girls. It most commonly begins within 1 to 2 years after the onset of menses. The symptoms that are associated with dysmenorrhea are pain in the lower abdomen, low back pain, pain radiating down the legs, nausea and vomiting, fatigue, weakness, diarrhea, and headaches. The types of dysmenorrhea are primary dysmenorrhea and secondary dysmenorrhea. In the primary dysmenorrhea, there is absence of the identifiable uterine pathology. It onset within the 2 years after menarche. Menarche is the first occurrence of menstruation. In many women with the primary dysmenorrhea, the pain becomes less painful as they get older, and it may improve after giving birth. The pain due to the myometrial contraction is induced by prostaglandin production in the secretory endometrium. In the secondary dysmenorrhea, it is associated with the uterine pathology, and these uterine pathologies are endometriosis, that is the most common cause of the secondary dysmenorrhea in the younger women, and it can result in the chronic pelvic pain and infertility. Second is uterine polyp or fibroids. The fibroids, if they are small, they may not cause pain, but if it is located in the wall of the uterus, it causes pain. Third is a complication of intrauterine device that is used for birth control. Fourth is adenomyosis. Adenomyosis is the common condition in the older women who have had children. Fifth is the pelvic inflammatory diseases. These are all the uterine pathologies that are associated with the secondary dysmenorrhea. Secondary dysmenorrhea onset at menarche or after the age of 25. It suggests that there is a possibility of the pelvic abnormality. The diagnostic clue include the infertility, pain or bleeding onset before menses. In the case study, we have a patient AB, a 17 years old girl. She is complaining of her severe cramping pain that is associated with her menstrual cycle. Her pain begins with the onset of menses and has been occurring for the past 5 years. She states that she is experiencing her first menstruation period after the age of 11. She describes her pain as like a fist clenching and relaxing, and the location is pelvic area and radiates to her lower back. She reports that she is not experiencing any headache, but she is experiencing diarrhea and some nausea without vomiting. Her symptoms are severe during the first 12 to 24 hours of her menses, and the medication that she is taking for when the pain begins are 2 acetaminophen 325 mg tablets, and then 1 tablet after 4 to 6 hours as needed with little relief. She has no allergies to other medication, and her physical examination is also within normal limits. So, by concluding her chief complaint, that is the severe cramping pain that is associated with her menstrual cycle, the location is pelvic area and lower back, and her pain is characterized as a fist-like clenching and relaxing. She's also experiencing nausea and diarrhea, and the severity of these symptoms are within the first 12 to 24 hours, and the only medication that she is taking is acetaminophen, and the current allergies are none. And the physical examination is also within her normal limits. So in the assessment, we conclude that AB description of pain as a cramping relaxing cycle is typical for dysmenorrhea. The cramping pain in the suprapubic area, and it radiates into the back and the thigh. The nausea and diarrhea that she is experiencing are also the typical symptoms of the primary dysmenorrhea. So AB pains begin within the 1 year of menarche, and her physical examination is also normal. So we can begin the effective therapy trial without the further investigation into the secondary causes of dysmenorrhea. AB symptoms that are typical of dysmenorrhea, and some women also experiences flushing, loss of appetite, irritability, nervousness, and insomnia. So as we conclude that she is having primary dysmenorrhea, in the primary dysmenorrhea there is an importance in history taking, and the physical examination for primary dysmenorrhea should reveal that she has normal external genitalia and normal pelvic examination with no anexial tenderness, masses, or nodules. As in the primary dysmenorrhea, the prostaglandin F2 alpha and E2 causes the vasodilatory properties, and it also induces the nausea and vomiting that our patient is experiencing. And the diarrhea and the nausea may cause by the elevated prostaglandin levels. So this also explains the rationale for the inflammatory drug uses such as NSAIDs, which inhibit the prostaglandin synthesis, and the combined oral contraceptive, which minimizes the progesterone increase typically seen in the luteal phase. So both NSAID and hormonal contraceptive can be used to relieve the symptoms of the primary dysmenorrhea. Non-steroidal agents or NSAIDs should be tried for 2 to 3 cycles before switching to other agents, and in the hormonal contraceptive, it may require 3 or more months to provide the maximum relief of the symptoms. So in the management of the symptoms, we use NSAIDs, which is diclofenac 50 mg per oral thrice a day, and in some patients, we give the first dose consisting of 100 mg, then followed by 50 mg twice a day. Naproxen sodium can also be used, which is also NSAIDs, and it can be taken as 220 mg to 75 mg or 550 mg per oral as a first dose. Celecoxib is the COX-2 selective agent. It is taken if the patient have the history of the bleeding or ulcer, because it decreases the risk for GI adverse effect. 400 mg per oral as a first dose or 200 mg BID, which is twice a day. Oral contraceptive can be taken alone or in a combination with NSAID, and it is considered as the first-line therapy, first-line treatment in the woman without a need for contraception. Melody, that is consists of desogestrel 0.15 mg and ethinyl estradiol 20 microgram. For her nausea relief, we can take antiemetics such as chlorpromazine 10 to 25 mg per oral, up to 4 to 6 hour interval, and as per needed. There should be lifestyle modification, as our patient should be educated about the causes of the primary dysmenorrhea. And normal non-pharmacological therapies have benefit in the relief of AB's symptoms. These are including aerobic exercise. Aerobic exercise may be owing to the improved pelvic blood flow and decreased ischemia that can improve our symptoms. Heat plus ibuprofen demonstrate a reduction in the time of the pain relief compared to the unheated patch plus ibuprofen. Diet that is rich in calcium, magnesium, omega-3 polyunsaturated fatty acid can also decrease the intensity and the duration of the symptoms. Cold or sour food should be avoided, and especially 1 week period or during the menstruation. The treatment efficacy can be monitored by evaluating the pain relief and improved functionality relief of other symptoms associated with dysmenorrhea. The regimen of acetaminophen that AB is currently using is not providing her relief owing to the lack of the effectivity on the prostaglandin activity. So we can use the non-pharmacological therapies that are life modification, which are potentially beneficial and the low-cost suggestion for the pain relief in addition to the drug therapy. NSAIDs have a lot of adverse effect relating to the GI problems, CNS problems, and other many adverse effects. So there should be a careful attention while giving the NSAID and the previous trial of NSAID for dysmenorrhea or even other conditions, because women may respond to one type of NSAID favorably over the other. And if the 2 or 3 month trial of months NSAID is unsuccessful, then we can switch to another agent from the different class of NSAIDs. Women who are allergic to aspirin or have the history of allergic reaction to any NSAID shouldn't take NSAID or even celecoxib. As our patient is having no allergies to any other medication, we can give it to her easily without any problems. And there shouldn't be any laboratory tests as the history taking is more important in primary dysmenorrhea. But unless there is a secondary dysmenorrhea, we can take pelvic ultrasound, laparoscopy, hysteroscopy, and it can be indicated for secondary dysmenorrhea. Thank you.